Hey guys, this is Koyo here, and I'm here with Shiki.
Yeah, hi.
Yeah, so now we're recording a new thing, Trauma Center Second Opinion. We'll come back to Metroid, don't you worry. But um let's just say I'm a person of medical expertise, sort of. Yes, I don't want to say too much about that because there's a great advice from many people in the medical field who will tell you not to say too much beyond you are a medical person.
Yep.
Yeah.
That checks out.
So, we're gonna play Trauma Center. I'm gonna be playing on easy because I'm a baby, um, and we're gonna see how. So I have played this in the game in the past, but I actually have like zero memory beyond the actual first like thing. So, yeah. Shiki is the one who actually suggested I play this.
Yeah, because well, not just because of your medical background, but this game is just cool. And for those of you about to judge Koyo for playing this on easy, I've watched people play this game on hard because I was way into it for a while, thanks to the Game Grumps. And this game is just freaking hard. It's like as hard as actual surgery, I would imagine.
Hmm. And that's another thing. So surgery is certainly not my expertise. It's other things that are among my expertise. So, like the only thing I'm still actually going to give medical like knowledge on, hey, them doing this makes a lot of sense because blah, blah, blah. Actually, I know I'm not getting right into the game, but did you know that Trauma Center has 5 games? Did you know that, Shiki, with your new live 2D model, which looks beautiful, by the way?
Thank you. The artist and rigging person did such a good job on this model. But no, I had no idea that there was more than the one Trauma Center game. I'm surprised to hear that it's so big and popular.
So the DS one, I don't know if it actually even took off, to be honest with you. But the Wii one, I think, did, because that's when I heard about it. I heard about Second Opinion. So there was Trauma Center Under the Knife, and Second Opinion is just a remake on the Wii of the DS version. So it's just a better looking version, and everything overall with revamped controls and everything. I'm sure it was easier using a touch pen as your scalpel, though. That would make like a lot of sense. And then
That would.
there was apparently a Trauma Center New Blood which also was on the Wii. That's a third entry, or I guess a sequel to the Wii one, and that one was on the Wii they put it on the Wii again because clearly that one did pretty well. It was released 2007, and then 2008 in Japan and Europe, which must be really strange because usually it's like, surely a game like this would come out to Japan first. It came out to America first, which is unusual.
Wow.
And then Australia got it 2009. Or Australia. They probably were
Sorry,
like,
Australia.
PS3, PS3, or 360, 360. I don't know. And then Trauma Center Under the Knife 2 came out, which was a sequel to Second Opinion. So even though New Blood is like another game, it's not the actual sequel. Under the Knife 2 is the sequel. Yet, what's funny is, it's a sequel to Second Opinion, but you wouldn't know it was because they called it Under the Knife 2, which is a sequel to the DS one, but it's also a sequel to Second Opinion because that's just a remake. So yeah, and then the final one was Trauma Team, and I don't know if that made it out of actually, yeah, any game after I don't think made it outside of America and Japan. It seems like that, not from what I'm seeing here on the wiki, but yep, that's a thing.
Well,
and that one's a
very
spin-off.
interesting. Huh.
So 2 spin-offs and only 1 actual like second game or second sequel game. So interesting.
So, do you want to take the narration here, or do you want me to?
I'm curious to see how you would narrate.
All right. Since its inception, Hope has selflessly served the community. One of the newest doctors here is still in need of guidance.
Wow, I was not expecting that voice, but damn, good job.
But He strives to improve out of an earnest desire to help people. Dr. Derek Stiles will soon come to realize his full potential.
Derek Stiles. Damn, that's such a name.
He's about to style all over this operating room. He's just going to be operating DMC style.
Yeah.
Just some Devil May Cry music kicks in right as he makes the first incision. Hope Hospital.
Consultation room.
Saw you?
Oh, the patient has been moved to the pre-op area. Mary Fulton, age 39, Hope Hospital's veteran surgical assistant. She's kind and well-liked, so nobody mentions she tends to ramble too much.
Mary, you ramble too much.
The injury is located on his forearm, and he's still fully conscious. We should be receiving blood test results from the lab any minute now. Okay, so yeah, so another thing, so I'm gonna go into a lot of medical stuff here. Please forgive me for all the pauses, but it's that people understand how this stuff works. So before anyone goes into surgery, you need to make sure to not only collect their vitals, but you want to have their lab work too, because one, you're trying to, verify, are they stable enough in terms of, like, say if the person suddenly started having a fever before they even went in, it's like, well, we don't want to infect that person anymore. They might have an infection or something going on. Or if they have, like, if their hematocrit levels, or in other words, their blood levels are, like, really low for some reason, then they probably don't want to operate or open someone up because they're already really low on blood unless it's an absolute emergency. They would need to first, maybe infuse some, packed red blood cells. Or whatever they might need. Oh, or if their clotting is really low, if their clotting factor or their platelets are really low, then when you open them up, you're not going to be able to stop them from bleeding. So you're going to have to bring that up first. So that's why they check before sending a person into surgery.
Yeah, Lord forbid you start operating on a person and they go into shock.
Oh, geez, yeah. So that's where you have to watch for their temperature, their pulse, and as well as their blood pressure. Oh my gosh. If your pulse starts going high, your temp goes high, and your blood pressure goes low, those are like very shock-like symptoms, especially systemic shock. You can have other types of shock too, cardiogenic shock, which would just be a high, I think it's both high blood pressure and pulse. I need to know this for my board exam tomorrow. Oh boy. I shouldn't be saying maybe. I should know. It looks worse than it is. He's not in any real danger. You might say he got lucky. Dr. Greg Casal, the head of Hope Hospital's surgical department. He's not easily rattled, but he's strict and expects perfection from his subordinates. You'll be operating Derek.
I will.
No, I'm joking. Do you want to do Derek?
Sure. I will?
Derek Stiles, age 26, an inexperienced surgeon, the story's main character. He just completed his residency and is accepted at a position at Hope Hospital. Why am I doing the Judge Judy voice thing?
I was just about to start my rounds, so...
Oh, worry about that later. You're not an intern anymore. Hurry up and prep for the OR.
This is a simple extraction procedure. There's nothing to worry about.
I'm sorry, I was supposed to... Just take your time. Stay calm and keep it steady. You should be able to handle this on your own by now. Okay, lacerations and foreign objects in the upper right brachium. Requires removal of the foreign objects and suturing of any wounds. Okay, so... Oh, let's begin the briefing. Our patient, Kevin Turk, just arrived in an ambulance. He lost control of his motorcycle. Oh, shit. Okay, so,
wow.
This is actually a great case study. So, if someone gets into a motorcycle accident, one thing we especially worry about, is funny enough, what was it? The possibility of, like, respiratory issues, shock, etc. Because what happens is when there's an insult to the body, such as, a laceration, etc. Actually, even worse than that, even before shock, we're worried about a person going into respiratory distress. And how that happens is when, as I said, when there's an insult to the body, it's like the body pulls all its resources to that one spot, and it starts the what was it? And the person could go into respiratory distress syndrome because of the inflammation. What was it? The inflammation system that occurs in our bodies. Things get inflamed, our lungs have a harder time breathing, etc. So he received a number of lacerations which have begun to hemorrhage. So hypovolemic shock, I imagine, is what he probably is experiencing right now if they have to surgically work on him. I don't know if he's knocked out. He probably is. There are glass fragments lodged here in his right forearm. Our cosmetic surgeon is out at a medical society meeting, but you should be able to handle the stitching. It's fairly straightforward. There are two main objectives in this operation: suture any lacerations, extract fragments of glass from beneath the patient's skin. Be thorough and try best not to leave any scars. Okay, let's.
Okay.
Sorry.
What happened to my voice there? Let's just get started. Nurse, I need 50 cc's of voice acting.
Administering now, doctor. All right. Let's begin the operation. We should start with those lacerations. Take the stitching needle. So we're going to... Oh, we're starting on this one first? Okay. Come on. They let me make some big-ass stitches. Of course, it's only a basic surgery still. Now do the same with the other laceration. Oh, wait. Maybe it's... I'm trying to see when it... Okay, that's good enough. Well done, the lacerations have been taken care of. Now take your forceps to remove the glass. Okay, so we're gonna have to be very careful.
Oh, that glass is really near the rib cage.
Oh. Okay.
Nice.
All the visible glass has been extracted. We need to take care of those smaller wounds now. Hit the antibiotic gel. So I'll explain this after I'm done. I mean, I'm sure it's obvious why we apply antibiotics, but medicine has come a long way. The gel can actually cure small... if only! Okay, it's paused.
Right.
So I'll take this moment to explain. During surgery, it's very important to administer antibiotics because you are opening the body. And while they try to keep the most sterile environment that they can, microbes float around, so we need antibiotics need to sometimes be on board in order to still prevent an infection from happening, because no matter what, infections can still happen. Now, I haven't seen one happen during my experiences with patients coming back from surgery, but even then, it is beyond crucial, because it really does make a big difference to the patient. And then on top of that, we want to make sure that the, even beyond just like antibiotics, typically, like, it's, like, the whole point is keeping it sterile, and then, yeah, just preventing any, it's prophylaxis, or in other words, preventative. The whole point is preventative measures, because it's better be safe than sorry. In the
Absolutely.
past, cure-all ointments are just gimmicks and scams, but somebody finally created a real one. Can we get someone on board with this? Can we make a real ointment that actually, like, cures wounds, little small wounds? Oops, I shouldn't be talking so much.
Please.
Let's continue. Some glass shards are embedded in the patient's arm as well. We'll need to extract those. Make an incision in the upper epithelium. So the epithelium is referring to, like, the skin, essentially.
Right, the epidermis.
Don't forget to... Actually, she would have said, like, epidermis or, subdermis. Don't forget to disinfect the area beforehand. So, yeah, you want to disinfect before you start this. Obviously, you don't want any bacteria, even if you have sterile supplies to, when you're opening up the patient.
Yep, that happened to a friend of mine, actually.
Oh! We can't let them get infected. Okay, so we're gonna pull this out. Oh. We're gonna We're gonna disinfect the area afterwards. Okay.
Get all up in there.
Now we just gotta close it up. Oh, this one's bad. Oh, okay, it said cool. Nice.
Yeah, it was cool. It's all good.
We're just about done. You shouldn't relapse just yet. So, another thing is, we call this, was it once? Oh, there we go. When, what was it? When the wound is closing, you know, when we see it healing, we want to watch for if it's approximated or whatnot, because if the wound isn't approximated and it's for some reason like inflamed or anything, then you know we got to worry about that too, because those are the signs of like possible infection, etc., inflammation. So it's good to pay attention to how a person's wounds are closing up.
Now, question for you about the closing and healing of wounds.
Yeah.
Since scar tissue is just a thing that happens, what leads to a keloid scar?
A keloid scar. Okay, so I was not taught about keloid scars. I'm wondering what that is right now. Let me see. Oh, okay. So I've seen this. I don't know. Like I said, this was never covered in my books. Probably because I wouldn't be dealing with surgery or anything like that, but let me see if I could understand the reason behind that. Yeah, raised scar. I wonder if it happens because, let me see. Wow. Yeah, I've only seen a keloid scar on like, who was it? It was like my grandma or something. Um
Yeah, sorry, that kind of came out of left field there, but I was curious because I just happened to look over and see one that I have on my body. So I was like, I wonder what causes that.
Oh, okay, that makes sense. So so if okay, so to explain the recovery process of the body. Wow, I got a C for that. I thought I did great, but so to explain the recovery process of wounds, one thing we worry about with a lot of our patients is their albumin level. Albumin is like a measure of nutrition and a few other things. And in regards to that, the big thing is how that helps with recovery, as well as controlling osmotic pressure gradient within the patient, where their fluids move, etc. So if they have a really low amount, they'll start to swell in certain areas. But more importantly, if they have a low albumin level and the person gets an injury or gets a pressure injury, God forbid, if they're a patient that's immobile, and they get a pressure injury, meaning pressure causing the wound to start caving in and whatnot. Not just any wound, but skin alone. They'll have a slower time recovering. So, what was it? Usually we pay attention to how much protein intake these patients are taking, right? Because we need them to recover. So we often make sure they're getting their protein so that their wounds can recover. However, it seems like a keloid scar forms when there's too much protein production in the healing process. So what that keloid scar is actually just a lot of protein that overhealed the wound.
That makes sense because I was doing a lot of weight training when I received that injury. So all those protein shakes and stuff probably resulted in that.
That maybe adds up then. I mean, that's at least like the small understanding that I got of it, and then using my medical knowledge of lab work and etc. to understand how that whole process works. Like that might, and see, that's like unnecessary knowledge for me. Even that's just I've always been told like I look far too deep into things. I should just be focusing on like not that, not the ultra small details. But I get really fascinated with a lot of different things. See, you're catching on quickly. That wasn't so hard, was it?
I couldn't have done it without my lovely assistant. Who are you again?
I can definitely see the improvement, but it seems your memory needs some work. Learning isn't everything. Seriously though, keep practicing and you'll do just fine. Learning the ropes. Alright.
There's a joke I could make there about rope, but moving on.
Judging from the MRI, the tumor is isolated in his stomach. It's benign. Okay, so benign means that it's not active. It might not be an issue per se. It's like, it's not a growing tumor. So it's just like a little tumor that might not be cancerous, essentially. But you should be
I'm
prepared
not a
for any.
baby, I'm a tumor.
The which one?
Oh, it's a joke from Hellboy. Yeah, there was a demon creature, and Hellboy was like, cute kid. And then the child just looked up, and he's like,
Baby, I'm a tumor.
Any questions, Dr. Styles?
huh? Oh, yeah, is it dissociate or disassociate? Because I was doing one of those. Yeah, I'm fine. Thanks anyway.
Are you even listening? Are you dissociating, sir? I know you're stressed, but your dissociating is not your job.
What?
Are you still dissociating? Why are you dissociating? Have you been sleeping? You need at least 6 hours a night. I'm sure they went over that in med school.
Tell that to my boss at the factory.
However, you probably need 8 hours to not dissociate. These patients are depending on you to...
Well, that sounds like a them problem.
It's like, Derek, don't forget the follow-up appointment with Mr. Jenkins this afternoon. Also, I know they need to get good and they don't have a lot of skill, but like, living's pretty tough even for me, man. Don't be so hard on them. I'm trying to get good, but those patients can't. Have you read the report?
I haven't actually. I can't read.
Oh, that hurts my soul. If someone says they haven't read the report, like, I don't know how much time he was given, but I would I would be scared if I heard that. And I've been scared multiple times hearing that. So, it's important to read the doctor's notes or, whatever notes, because it gives you so much insight into what's going on with the patient.
Well, yeah, it's like your tutorial for that patient.
Yeah. You need to shape up. This is real life. We aren't playing games. You've been here 3 years, Derek. We shouldn't still have to babysit you. So, funny story. A lot of people in the medical field actually, and I've heard this commonly even from new doctors, is that even after a year, you'll never feel comfortable or ready. And we're all just making sure we're like, trying to be as there for each other as possible, because it's still like, the medical life is a very difficult process. So this is a very hostile environment right off the bat. Like 3 years though, I would say after 3 years you should be feeling a little better. But I know the first year is always the hardest for everyone, and then the second year is like, it's a little better, but people say it takes like 5 to 10 years. This might be grounds to an open investigate. Jesus Christ, that's bad.
Oh.
I mean, unless he's been doing this the whole time, then I totally understand. This would be, like grounds for an investigation. I get it, but if this is like the one time he's doing it, like that's a little bit much. The impaired medical and social development of Dr. Derek Styles. Wow.
Harsh. Cut me some slack, Marv. Mary. I thought that said Marv.
You're not a resident doctor anymore, Styles. You know that. By the way, Mary, I spoke with Dr. Hoffman. Oh, thank you very much. Has he been hoffing? No, he's been man-hoffing.
Wait, you spoke with director Hoffman? You mean Jack Me Hoffman? About what?
Don't worry, it's none of your business. We're just ragging on how bad you are. It's a personal matter. Forget I ever mentioned it because it totally involves you.
Are you going on vacation or something? I wouldn't mind a nice, long cruise myself. Lounging in the sun, the sea stretching.
Okay, that's enough. We have an operation to perform.
Oh, no way.
So
I don't know why I gave him that voice.
Yeah. The tumor is confirmed at the surface of the stomach. It should be removed before it becomes malignant. So, I mean, it's not going to become malignant that fast, per se. But, just to explain how was it some interesting things about tumors and whatnot. So especially like when you have cancer, those tumors are like actual, like the closest thing to a vampire you would actually find within your own body. They love your blood, and even more so, they love sugar. So typically what's getting slowly more and more recommended today is actually, I mean, not to outright cut out sugar from your body, not instantly, but they have been recommending keto diets because in reducing the sugar and carbs that your body gets, it actually really slows down the tumor. And I've actually seen these results in person multiple times. It definitely works, it definitely makes a difference, and it just gives more time to actually do something about it, especially since the patient might have to be waiting a while to actually, have surgery done on their tumor, depending on where they're at. But yeah, for the most part, that is one of the newer recommendations, and still to accompany that with BCG and essentially like, was it any kind of chemotherapy, that kind of stuff, using that in conjunction together does wonders, or at least it makes a big difference. So we need to excise a tumor in the patient's distal stomach. 2 years ago, testing indicated that it was small and benign. However, it's grown rapidly and started to hemorrhage. I love that. Like, I would have never understood this medical terminology 2 years ago. Now I understand it. I'm like, yeah, hemorrhaging. Okay, I know what's going on. So, at this rate, it might become malignant. After talking with Mr. Laurie, we've decided to remove it. There is one objective in this operation: excise and remove the tumor from the patient's distal stomach. That is all. But you'll need to remove the tumor using a Powell procedure. Now, see, I don't know about surgery stuff, but that sounds familiar. First, drain the tumor's cytoplasm to decrease its size. Okay, so then once you excise it, the cells can't metastasize. Metastasize means that the cells won't be able to move around, especially in the body. So what we worry about with cancer cells is metastasis, which means that the cancer will go from like one place to another part of the body because it travels via the bloodstream. So one thing I've actually seen in a patient was he had bladder cancer, and over time he started to, he didn't realize it was there until it started to hurt when, he'd use the restroom. And they found out later when doing an X-ray, it metastasized or moved to his lungs. So in that, so that's a big worry for us. I mean, of course, it was found early, so it's easy to treat. Well, not easy, but treating cancer in its early stages in the lungs is far better than when it's like in the third or fourth stage, which you don't want it to be at. There seems to be a trend towards this type of removal. It's a good idea for you to learn it. So, draining it, let me think. I think they're... I'm not sure. Like, a reason to even, like, drain stuff as well of the, fluids, etc. Like, for example, we do that with the heart when there's, not hypervolemia, I forget the word, but when you have a congestive heart failure, and there's a fluid overload within the heart, you have to drain it because then it becomes too hard for the heart to really function. But different types of drainage are performed in the medical setting for a lot of different things. This will be a laparotomy. You'll need to open up his abdomen. You've done this before, so there's no reason to be anxious. Let's begin. Disinfect the area and make your incision. Okay. Okay.
Do it.
Alright, in we go. We're going to treat a tumor, but his vitals are dropping. We'll need to use this syringe to stabilize this condition. Insert it into the vial first. So, vitals are stabilized. So, in regards to this, good thing it paused. Most likely, I don't know in which way they were unstabilizing. I don't know if it was going... Well, they said it was dropping. So, that's interesting. I'm trying to think of what they would have given. Because once again, I'm not specialized in surgery or anything of that sort. Like, surgery room is not where I'm gonna be even in the future. But I'm like, I doubt they would have given like what, epinephrine or something. So maybe they would have given like amlodipine or one of the penes, which causes your vitals to go up. But even then, I can't think of what that medicine might have been.
Well, the only indication for vitals they give you is that health meter up there, which vaguely behaves like a
pulse.
EKG. So
Yeah. So if his
So it's
pulse
kinda
was
hard to
going down,
tell.
then yeah, like amlodipine or something. Let me make sure about that. I'm just gonna pause for a moment. Okay, sorry. I said amlodipine. I meant atropine, which helps treat like a slower heart rate rhythm. But it's just we're not even at that point yet. So I was like, oh, we're just prophylactically giving atropine or something like that to increase his heart rate or something.
Sure. Yeah, like I was saying, I mean, we have no idea. There's no indication of like blood pressure,
Yeah,
oxygen or anything. We only have that health bar up there.
exactly.
And,
However,
and,
yes.
and I'll preface that by saying, folks, I have no clue about medical stuff. Like I was telling Coyoda before this all started, so my father, wonderful man, he was a volunteer firefighter, he was a paramedic, he was practically a certified EMT, and he later went on to work in a hospital, so best I could do is stabilize somebody to some degree, and then let a professional, like our dear Coyoda, handle things from there. Just because I can reset a bone doesn't mean I know how to do surgery.
Yeah, same here. Yesterday's test revealed something in the patient's lower stomach. We'll need to use this ultrasound to find... Okay. So I'll have to use the B button. You'll notice that the... Okay. Oh, almost lost sight. So, directly over the tumor. Right, let me do that, though. Okay, that's right. There's definitely a problem. Let's expose the tumor. Okay. It's pretty big. Looks like we did it just in time. We'll be using the Powell procedure. So, we're going to use a drain. We're gonna... Okay, we've completed the first step, draining the cytoplasm. The cytoplasm will continue to ooze out if we don't do anything to size it. So now we gotta pick out that part.
Oh yeah.
So, removing... Exactly, synthetic, we gotta stop the bleeding. Oops. There we go.
No, I'm sure it's fine for there to be a big hole in the stomach. That's where the food goes, right?
Yeah, then it'll come right out, and their gastric acids will essentially just bleed all over. I mean, will just bleed out, as in like come out onto the rest of their body. It's made of protein, so there's no. Hey, yeah. So that's a funny thing. So the synthetic membrane that they could put on surgical healing areas, they make it with protein because to prevent tissue rejection. And how you would know there's any kind of rejection happening, say when you put in a new set of lungs into a person or kidneys, etc., is they'll start to get a high temperature typically, and we gotta pay attention to those fever signs because that's rejection.
Right, because the body would treat it as a foreign entity, yes?
Exactly. Now finish the operation by suturing the... Okay. Boop, 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 boop. Uh-oh. Uh-oh. Uh-oh.
Oh gosh.
Bad.
Oof.
He's fine.
Yeah, he's fine. See, it's closed up.
How was that one bad? I put it right on.
I think she's just judging you harshly.
Yeah, she must be. C rank, right? 1 cool earned. Hey, I got a B! That's a little better. Nice work, Derek. You really took your time and did things right. Just remember the patient's safety. Yes, 100% this. Safety first in all medical stuff. Like, beyond anything, like, I don't care what it is. I don't care, like, if you need to take a little bit more time to do something just to ensure the patient's safety, that is literally the most important thing beyond anything. Literally anyone will not... Like, if someone bashes you in the medical field for trying to be a safe, practitioner, etc., then they need to leave them. I'm actually genuinely saying this, they should not be in the medical field. Safety first. beyond anything. Like, genuinely. Anyone who
I
tells...
actually have a...
Huh?
I was gonna say, I actually have a card I have to keep in my wallet because of my job that tells medical professionals to take their time with me in case of a certain type of injury.
Yeah. You're getting better every day. Keep up the good work. You're getting better every... Well, yes, that's actually a really good compliment, but not after she was like, you've been here for 3 years. I'm like, wait, why are you acting like this is my first time, though? Are you talking to me, the player, or Derek Styles?
Next time on Trauma Center, the Lion, the Witch, and the Audacity of this bitch.
Oh, possible nurses station. And so, since my husband's been relocated to a different office, I'll be leaving Hope Hospital, effective immediately. Ha! Good luck, Derek Styles, you freaking loser! I'm really gonna miss this place and all the friends I've made here. Not! Smell you later, dweeb! But I
She
promise
just comes up behind Derek and she's like, Derek, I'm smelling you later. But later is now, though.
But I promise to continue my work as a nurse, wherever life takes me. Oh, I see. Yeah, she's gonna. Basically, what that means is like, oh, I might not be in the surgical floor or whatnot, or surgical assistant, but she will still be a nurse in like any other kind of department. You all taught me that nothing is more satisfying than helping patients. It was a pleasure to have you on staff, Mary. Good luck with your new job.
Oh, I can't believe you're leaving so all of a sudden. I was dissociating again.
How are you going to get by without
leaving?
dissociating, Derek? Man, I swear, you should be called Dissociate Styles, because you dissociate and style all the time.
What?
Exactly. Actually, Derek's the one reason I was a little hesitant to leave. I even spoke with my husband about it. I told him there was a kid here who depends on me. Aww. He asked me how long I'd been working in pediatrics. No, that's so mean! Oh my gosh. Pediatrics is, you know, children, the babies and children. Oh my god. Called Derek Styles a baby.
Oh, come on, I'm not that bad, Mom. I mean, Mary.
Aw, you're just baby girl, don't worry. Who's gonna do this one?
I guess I will. Hey, later. Is Nurse Fulton still there?
Oh, hello,
Don't
Dr.
worry.
Hoffman.
What? I'm not interrupting anything, am I? What happened to my voice?
You only work for snappers. Robert Hoffman, age 62, the director and founder of Hope Hospital. He used to be a renowned surgeon, but then he retired to work in management. No, of course not.
I came to say goodbye. Goodbye. Anyway, I won't be around tomorrow. Thank you for your many years of dedicated service. You're a fantastic nurse, probably. Oh, probably our best.
He looks like he is falling asleep. Like, his eyes are just barely visible. He's like...
Where am I? On behalf of our entire staff, I'd like to say thank you.
Oh, sir, the pleasure was all mine. I wish there was some way I could thank you for this opportunity.
Oh, there is. It's called the San Diego Thank You. I mean, you're not gonna stop nursing, are you? If you continue to help people, that will be thanks enough. Or a San Diego Thank You. I mean, that's still on the table.
Of course, sir. Wait, sorry, I'm just adjusting speaker volumes. Of course, sir, helping people is my life. It's just, I wish I could stay and learn from you a little longer.
Don't be modest. You're not even good at it. You already know everything I could teach you.
So, hopefully, I'll mention it later.
I'm afraid Dr. Casal surpassed me as a surgeon long ago.
Dr. Hoffman. I don't know why I suddenly went like that with his voice.
Shut up, you handsome piece of yowie meat.
Yeah.
Good luck with your new job, though. Don't be a stranger, alright? At any rate, I have other matters to attend to. If you'll excuse me.
I wish I could have seen Dr. Hoffman in action more often. They say he hoffs a lot, but he hasn't performed any operations since that incident. Actually, I knew a Hoffman back in a certain school, and perhaps I shouldn't be saying Hoff. What was it? He hoffs a lot, because then that's making fun of people who have Hoffman as their last name or even their first name, for all I know. So I'm sorry.
I think it'll be okay.
Oh, yeah, sorry. Derek, let's discuss the next patient.
Yes, sir.
This will be my last procedure, I hope, so don't let me down, Derek.
I'll be sure to let you down.
Multiple tumors confirmed in the pancreas. Oh my gosh, pancreas. How is this? Oh my god. Okay, so this is a very serious thing. Pancreatic cancer is like, I think next to actually any type of gastrointestinal cancer is very bad because it's often found late. Hopefully they found this early, but even then, the life expectancy and everything in regards to pancreatic cancer, gastrointestinal cancer, or even liver cancer, it usually tend to be pretty low, or even the chance of survival. So when I see it, maybe I could have a better idea of where they're at stage-wise, hopefully. Maybe this is the first or second stage, which would be a freaking godsend, you know? Multiple tumors confirmed in the pancreas. They may lead to a loss of stamina, so immediate removal is highly recommended. And not to mention, if they're operating on the pancreas, oh my gosh, that's gonna set off, like, what is it? Because that's a very sensitive area for the body. If there's an infection there, or an abscess, or, you know, anything with the pancreas, I've had like 2 or 3 pancreas patients, and I know with one of them that I had, like, there's a lot of nausea and pain, and oh, it's awful. I feel so, like, I never want to have a pancreas problem. It is not fun. Yesterday's procedure went very smoothly. I want you to handle Mr. Spence's operation today. It's another tumor incision. Just be careful. There's more than one this time. Make sure you don't miss it. If there's... This is the last time I'll be assisting you, Dr. Stiles. If you can handle this operation, I'll feel much better about leaving.
Dots.
Oh, I didn't mean to upset you. Dots. But wake up, Dr. Stiles. The only person you should be thinking about during your operation is the patient. Absolutely. Do you understand?
No, not at all, but here we go.
Let's review the main objective, then. Excise and remove all tumors from the patient's pancreas. Now think back to yesterday's procedure and begin.
Here goes. Let's begin.
I have never seen any doctor or anyone go like this before oh god, my hand. Go like that before starting a procedure. They're like, let's begin the operation. Like they don't do that. That's not
Yeah,
a
did he
real
even
thing.
scrub up?
The which one?
Did he even scrub up?
No. I mean, maybe it's off screen. Okay, so we got disinfect. Okay, and then cut in. The pancreatic membrane is inflamed, so we'll need anti-inflammatory. Yeah, especially, okay, so when it comes to the pancreas, as I was saying, inflammation is a big thing. Now jet the other one. Okay. Good, the swelling's gone down. Let's move to the tumors. Yeah, so with the pancreas, yeah, as I said, it easily gets inflamed, and when it's inflamed, your patient is, like, literally going to be, you can easily confuse it for, like, fever symptoms and stuff, too. The pancreas is so important. Let's move on to the tumors. 3 tumors have been identified in the patient's pancreas. Perform ultrasound to carefully locate them. Okay. Okay. There's the other one. Okay. So,
nice.
Oh, okay, so let's do one at
they
a
don't...
time.
Oh.
Okay, let's get the forceps.
Wait, don't you have to drain it first?
Oh, yeah, right. That's the method they're using. Okay. Oops. Okay, not the best, but get out of there.
But you got it out. That's what's important.
Okay, then we got disinfect. Okay, and then where's my... Oh, okay. And then we gotta do the other one. Okay. And then we gotta go down. And then we gotta drain. Then we gotta... Oh! And then we gotta, disinfect. Oh, wait, no, we don't.
I hope if I ever have
oops.
surgery of this
Then
magnitude, the doctor
disinfect.
makes those same noises. Nothing would comfort me more than to be in that sort of waking state under anesthesia, and then to hear the doctor go, "Whoop-a-doop-a-doop-doop-doop."
Oh my god.
As well,
Right,
he's
wait,
having
no.
fun. I'm sure it's fine.
Okay. Wait, is there
Take
one
care of
more?
the affected areas. No, you got them. I think you have to put the biogel over the membrane.
Oh, thank you. Okay, thanks. Thank you so much, Assistant Cheeky.
Of course, doctor.
You seem to really be really focused today. I guess my work here is done. Perfect work, that styles. Let's close up the incision. Okay. Wait. Actually, just in case. I don't know. I'm just being overly cautious now.
Might as well. I mean, you're dealing with the... Yeah.
Okay, now I... Wait, what? I forgot how to take the... Oh, there we go. I just click it. Good.
Good.
I think we can both relax, Derek. You're doing the best. You're doing your best. It's probably like a C rank. Yeah, I thought so. You did a great job, Derek. It looks like I have nothing to worry about. You're gonna make an excellent surgeon. Please continue using your abilities to help the people of Angeles Bay. Of course it's Cali. Of course it's Cali, because you know, they don't have a ratio there, which is great. You know, they don't get overwhelmed too badly. Wait,
Sure.
what, did I just say they don't have a ratio? I mean, they have a ratio. Whoops. Oh, man. But
Those are certainly all words, Koyo. But
a patient to doctor or nurse ratio is essentially like how much patients that person can take on before, like, you know, yeah. So typically in Cali, it's supposed to be like 1 to 4. There's even some places are like 1 to 5, but outside, depending on where you're at, they don't even have ratios. So you could have like 12 patients, for instance, you know, doctor, nurse, etc., which is just, yeah, that's not fun. So
yeah, no, that sounds crazy.
it is. It absolutely is. But that's all we have time for today. I know I spent a lot of time explaining things, but I try to at least, you know, let it make sense. I know it's like, oh, just play the freaking game, but like, I can't help it. You know, this is just, you know, one of my interests in, like, you know, understanding things deeply, etc.
And that's why I recommended it, because not only of your medical background, I mean, Trauma Center is an awesome game already, but having somebody knowledgeable to break stuff down like this and compare it to the real world, I mean, that's game theory levels of, like, educational entertainment. So
And
that's what I was hoping for.
So far, like, there's things they're doing right here. Like, I played this game 2 years ago before I went medical. Well, 4 years maybe? It could have been longer, but I haven't played this game in a long time, and I barely got that far into it. And now that I'm playing it again, I'm realizing, like, yo, there's, like, information here that I understand, and at least, like, for me, being aware of the diseases and issues that occur in a patient is totally relevant here. And what they're talking about is, like, yeah, this is actually how it works. You know, this is how, you know, this is why we're trying to get rid of the tumor. This is, you know, So it's definitely like transferable in its own way, even if it's at a smaller level, and I like that because this is already getting like now I know for my board exam tomorrow what I'm gonna be looking into. I'm gonna be looking into the pancreas. I didn't see a lot of pancreas during my practice stuff now that I think about it, but I'm still gonna look into it now because you know, that's something, if it appears, I'll, you know, have knowledge of how to answer properly.
Cool.
All right. So with that in mind, guys, sorry for bumping the mic, and also sorry if noise from the game caught over my microphone. That's why I was turning down the speakers. You probably saw me leaning into Shiki there. It wasn't because I was trying to cuddle with him. No, it was because I was trying to turn down my speakers because I noticed I was like, wait, is that noise coming over onto my microphone? So I think my microphone's a little bit sensitive today.
There's a joke I can make there, but as you said, that's all the time we have.
Yep. We hope y'all have a good day, folks.
Yep. See you later.
See ya. Don't forget to like and subscribe and all that.
Bye.